So for those of you that don't know me, my name is Kristine Fraser, and I am the Pediatric Professional Practice Consultant with the Maternal, Newborn, Child, and Youth Network, which is MNCYN, out of London. So this is a very sort of different perspective of the CME prop lectures from previous ones, in that I am a nurse. And so what I was asked to do today is sort of do a head-to-toe systematic review of how to do a really good, thorough pediatric assessment, but this is from the nursing perspective. So a little bit different than previous prop lectures. I believe I'm the first nurse that's done one of these. So if there's any physicians on the line, hopefully you'll stay, but if you don't, I completely understand. So what I'm going to do is I'm going to talk to you, I'm going to go through some slides, and then at the end, I've got some videos that we'll kind of go over together. So let's see, I have nothing to disclose. And the learning objectives are really quite simple. It's really to improve your knowledge and increase your understanding of how to do a systematic head-to-toe assessment on a pediatric patient, and to really pick up on the clinical signs of deterioration in a pediatric patient. I often get told, kids get sick really fast. We don't know that they're as sick as they are, and they don't get sick really faster or than adults. They get sick different than adults. So it's picking up on those subtle clinical signs, and they do tell you when they're sick. They do show you those signs, but if you don't know what to look for, sometimes that's difficult. So we're going to go over some clinical signs of deterioration. And we're also going to, at the end, I've got a few resources and different nursing educational opportunities that are available around the region. So I'm just going to move this one and see this a bit better. Perfect. Good stuff. Sorry, I'm just moving my camera around here a little bit. There, much better. Okay. So with that being said, pediatric assessment. Normally when I do these presentations in person, I ask the audience their comfort level with pediatrics. Have they ever taken PALS, PAIRS, the emergency nursing pediatric course, ENPC, things like that. And typically I get back, we don't like it when a child comes into our emergency department or into our care, because it's nerve-wracking, right? You not only have a pediatric patient, but you also have their family to care for. So I do understand some of that kind of angst. So the first thing to know about pediatric assessment is you have to know what's normal. So my biggest suggestion for anybody working with kids is to get comfortable. Start doing a pediatric assessment on every child that comes into your department, whether they're there for a fractured finger, stitches, or they're really, really sick and they need, a lot of interventions. The more you do it, the better at it you become and the more comfortable you become. And then, if you've done a head to toe on all these kids, that one kitty that comes in that's abnormal or different, it's a lot easier to pick up on those subtle signs, because you're like, something is different. This kid doesn't seem to be the same as the last 20 kids I've seen. So the more times you do it, you get to figuring out how to check pulses quickly, how to do a cap refill quickly, how to get a cuff on them, a blood pressure cuff, and do it. Little tips and tricks about how to take a temperature, do a blood pressure, do a cap refill, all at the same time. And then you also figure out how to talk to parents. So there's lots of different places that you can get normal vital signs. Your PALS card, you can, as long as they're posted in your department or even in your name badge, sometimes people will print little cards out and keep them in their name tag. You really need to know, it's respiratory rate, heart rate, and systolic blood pressure. Those are the things you need to know what's normal and not normal, sort of right off the cuff. I would never expect anyone to remember all the different ages and all the different values. That's a lot of cognitive load to ask of yourself. But as long as you know how to find them and find them quickly, that's really what's important. So what is a pediatric nursing assessment? It is basically going through your systems from head to toe and back up again. So it's your airway, breathing, circulation, disability, exposure, and down. So we're going to go over this in a bit more detail, but I really want to push the point as well that you're not just treating the numbers you see on the monitor. Those are important and those are valuable, but you also have to look at the kid and put the two pieces of the puzzle together. So sometimes you know, when I teach out in the region, I get told, you know, the nurses want to really focus on the monitor, but they're forgetting to look at the child as well. If the numbers on the monitor look okay, and you look over at your kitty and the kitty looks awful, the kitty is sick, right? They don't really hide that very well. So it's important not to get too focused on the numbers and putting the two pieces together. And it's about treating, if the child looks sick, they're sick. Like blood pressure, we'll talk about that. It's a late clinical marker. So if they have a normal pressure, you don't want to just be like, well, their pressure's still fine, so I guess they're fine. You know, like it's those type of little subtleties. And it's looking at the trends and not just an isolated reading, right? So the very first thing that we usually talk about when we're talking about a nursing assessment is the pediatric assessment triangle. If you've ever taken PALS or ENPC, this is one of the points that we really hammer home. And it's really that first impression, and you're using audible and visual cues to sort of help prioritize, are they sick or are they not sick? And then how sick are they? So there's sort of three sides to the triangle: appearance, work of breathing, and circulation. So appearance is, you know, I'm walking into the room and how does the child look? Is their tone look okay? Are they really lethargic? Are they slumped over? Are they hypertonic? How are they interacting with their caregiver? What's their look like, you know, in their eyes? Do they look glazed over? Are they crying inconsolably? Like, what does it sound like? And then from there, I look at their work of breathing. And remember, this is before I get my stethoscope on them. Can I hear them breathing as I'm just entering the room? Are they grunty? Are they breathing really, really quickly? What's their position like? I just got told I was really quiet. So you can hear me okay? I'm talking pretty loudly. Yeah, okay. Jane's shaking her head. What's their body position like? So sometimes kids will sit in that sort of tripod position where they pop their head forward and they kind of pop their chest out, and they're trying to open their own airways. They sometimes look air hungry. If they come in, you know, like if I have my baby here and mom comes in with this baby and it's all wrapped up and all I can see is nothing, it's hard to know what their appearance and work of breathing is, which is why it's so important that we actually unwrap and take our kids out of car seats and whatnot so that we can actually do an assessment on them so that we can figure out if they're sick or not sick. And then the last piece of the triangle is circulation. And that's the color that I can see of their skin. So if they're very, very pale or mottled or cyanotic, those are the things that we would help prioritize. So if the child's been brought into emerge, they're already deemed sick. Somebody has thought they're sick enough to bring them into your emergency department, they're deemed sick. If one of the sides of the triangle is off, they're sicker. And if one or two or more of the sides are off, then they're your sickest and they got to get to the back quickly. And of course, we always reprioritize and we make sure that any unresponsiveness, apnea, pulselessness, anything like that obviously takes precedence, and it comes right to the back, and that would be sort of your resuscitation immediately. So the first thing that we've deemed this child sick, they're coming to the back, and sometimes it's a little bit overwhelming. You know, if you have a really sick child on your hands, and you're like, I don't even know where to start. What do I do? Like, it's so hard. There's like 75 things that are going on in your head, and you're trying to figure out. Start at the head and do a primary assessment. It doesn't take that long to do, and you hit every system. So it makes it more difficult to miss something of value. So we always start with airway and alertness. Are they alert enough to protect and maintain their own airway? So something we could talk about in PALS is AFPU. So it's, are they alert? Are they only alert are they alert? Are they only responsive to verbal stimulation? Are they only responsive to painful stimulation? Or are they completely unresponsive? If they're unresponsive, the likelihood that they're going to maintain and protect their own airways is pretty low, and we know we'll probably have to intervene right away. But if they're alert or they're sort of sleepy or lethargic, you have to determine sort of in that moment, is their airway patent and is it going to stay maintainable? Hopefully. Or is there anything I need to do in this moment to help help this child before I can sort of move down. So as I'm going through, I look at my airway. I would open the child's mouth. So if I have my baby here, I would open the mouth, I'd have a look in, and I'd say, yep, looks clear, looks great, next. If I'm looking and I can see any, any foreign bodies, or if I see a lot of secretions or mucus, I might need to suction. Sometimes if their airways just, they have a big floppy tongue and it slid down, I might just need to reposition them a little bit. A little sort of roll like this under the baby's shoulder blades. If you have a baby like this and you just put a little roll under their shoulder blades, it helps to pop them into sort of that sniffing position. Sometimes just doing something simple like that, head of the bed up 30 degrees, things like that are sometimes all that is needed to help maintain their airway. If it's really bad, sometimes we have to go down the oral or nasopharyngeal airway route. But if we're doing that, you need to know what the contraindications for those are. So why are kids' airways so different than adults? And they are. So I'm really talking about sort of that younger population, that 8 and under, and really specifically that 2 and under. So the really little kids. So first off, they have a big occipital bone. So when they naturally are laying there, take my baby's hat off, when they normally lay on their backs, their heads kind of pop forward like this because of this big occipital bone. So when they do that, if you look at the middle picture there, their cricoid cartilage is sort of a funnel shape. It's the narrowest part of their airway. So if I really have a hyperflex neck like this, or a really hyperextended neck, I sort of crush their airway a little bit in that I'm sort of making it more and more difficult for them to breathe. That's why that nice sniffing position is really valuable. Babies are obligate nose breathers until they're about 4 to 6 months of age. So if I have a neonate or a little baby that's come in and they're just chocked full of secretions and sort of plugged up in their nose, the very first thing parent is probably going to say to me is, baby's not eating, because they can't suck, swallow, and breathe if they're completely blocked in their nares. So that's where suctioning sometimes comes into play. The other thing is big floppy tongues. So if they've had a seizure or I've given them some sort of sedation, I have to know in my head that their tongue could be a problem and get in their way. So again, the roll, sitting them up a little bit, it's just things like that to know. And if I always feel like knowledge is power. So if I know that I have a pediatric patient that's come in that's in some respiratory distress, and I know their physiology is a bit different, then I can already think in my head, they've got a smaller airway than I do. They've got secretions in there. I need to help them get those secretions out to help make that airway bigger. I know their lung capacity is smaller. I know they have weaker intercostal muscles, and therefore they can only chug along so fast for so long before they become tired and start to become apneic or bradycardic. So I just feel like if you understand that, it does help you with your nursing assessment. If you do have to suction, just a couple of quick things to keep in mind. You should always check your suction pressure on your wall before you start suctioning a patient. So you just bend your tubing over, and it should be between 80 and 100 for a pediatric, an infant, or a pediatric patient before you start sticking the catheter down their nose. So check it first. And then you can either use a flexible catheter, like a regular suction catheter like this, or you could use something, we call them, they're like little Neo-T little suckers, they're called. And they look like this, and they're a little bit more rigid. They're still soft, but they're a little bit more rigid. And these are really great for getting up baby's nostrils. They can pull out a lot of mucus with these. And typically what I'll do is I'll put just a couple drops of saline down each nair first. Then I'll go in and I'll put my little sucker in, pull out some secretions, and that sometimes is all they need, and you're good to kind of move on. If you are using something like this that's a little bit more rigid, or a yonker, if you hit the back of that tongue, don't be surprised if they have a vagal response and they might become bradycardic. So try not to go back. We'll gag them and they might vomit. So we always try to avoid doing that if we can. So airway, simple. You're checking. Do they have one? Can they maintain it? Yep. Then you can move on to breathing. So you're at breathing. You're just doing a respiratory assessment. What's the depth, the pattern, the rate? Is it symmetrical? Is the air entry bilateral? do they have a work of breathing? Like, are they really working? And don't forget, as part of our respiratory assessment, our level of consciousness is in there. Because if they're hypoxic, they're going to have an altered mental status. Check their cap refill. Check their skin color. What is their saturation? And some of the things that we do as nurses is we might have to do some FiO2, give them a little bit of oxygen. Sometimes we have to give them some positive pressure ventilation using a bag valve mask. If we are checking our kids' oxygenation, I hate the word normal, but we use it a lot in medicine and nursing. Kids that have healthy hearts and lungs should have really good SAT, right? Their SATs, if they're coming in and they're a 5-year-old that has no previous history of anything, and their SAT is just like 92, 93%, that's pretty low. They should be well up into sort of the high 90s. And if they're already sort of drifting down and they're sitting sort of in that lower 90s, even though they're above 92%, I'm starting to think at that point they might need some oxygen, because if they fall asleep, their SAT for sure is going to drop. So they probably, I want to think early about oxygen, because I don't like a hypoxic kitty. The number one reason that kids end up going into really bad respiratory failure and or cardiac arrest is because of a respiratory reason. It's a hypoxia. So we try to avoid that as much as we can. So we like to get on our kids soon and quick, because if you remember all the physiology things, the sooner we intervene, hopefully the less chance that we have of going down a bad path. So we would give some oxygen. So you can do supplemental oxygen with your nasal prongs, with our neonatal prongs. But we have to remember, oxygen's a really dry gas. So if I have prongs on my little baby and I'm blowing a ton of, volume up their nose, it's really drying and irritating. So there are max flow rates that we should be doing for neonates. So remember, a neonate is less than 28 days. An infant is 1 month to a year. So there is a difference when we talk about that with kids. So about 1 liter for our neonates, 2 liters for our infants and our little toddlers, and 4 liters for kids. 4 liters is a lot up a nasal prongs. That's a lot of oxygen. So at that point, I'd probably be thinking about switching them over to using these instead, right? The trees, and then just dialing in how much oxygen I need with like with a venti mask. If they're really bad, then I would just put them on a non-rebreather, but hopefully you don't have to do that. So when I'm doing my respiratory assessment, I'm also thinking about what's their work of breathing. So do they have retractions? So these are very common sort of retractions that we might see with a pediatric patient. So suprasternal is a tracheal tug. That's the other name for it. It's just a fancy name for it. Up here above their clavicle, sometimes they really suck in up here. So when we're getting up here, they're sick, right? Intercostals between sort of that rib space, and you'll see them pulling in. And some of the videos I have some really good examples of this for you. And then there's abnormal breath sounds that we'll hear as well. So as I'm doing my respiratory assessment, I'm listening with my stethoscope, and upper airway sounds that are very common with kids. Stridor is a big one. Snoring, gurgling, and we hear those a lot with croup is a big one. Foreign body aspiration, we might hear that upper airway. Remember, they have small little airways, so when they get croup, they're really tight, and that's what you're hearing is the air trying to get through that tiny little airway. Lower airway sounds that we hear are wheezing, so that's that sort of tight whistling sound. Crackles, and if you actually take a piece of your hair and you kind of rub it by your ear, that's what crackles sort of sound like. It's a sort of fine sound, and that's fluid overload. And we hear those often with our broncholytics, our asthmatics, our pneumonias. And another sound that's common with sick babies and little young kids is grunting. So this is an audible sound. I don't need a stethoscope to hear it. That's heard during expiration. And it's really a sound it's a compensation that they're trying to decrease their work of breathing and improve their oxygenation. And you'll often hear somebody say they're auto peeping. So what they're trying to do is maintain their lung volumes. They're trying to avoid all those little alveoli in the bottom of their lungs from collapsing. So a lot of times broncholytics bronchiolitis is a lower airway disease. It's sticky, thick secretions, and they're trying to prevent all those little alveoli from collapsing, so they grunt. And I have a video of a baby grunting, so I don't have to do it for you. So, and it's a lung or a cardiac cause. And then the last thing sort of in the abnormal would be something called silent tachypnea. And this is something like Kussmaul respirations. Our DKAs do this. It's caused from a non-pulmonary reason, acidosis, fever, sepsis. And it's just the body's way of trying to normalize pH. So they increase their respiratory rate and their work of breathing. When you listen to them, they're nice and clear, their SAT is normal, but they're breathing quite quickly and they can look quite sick, but they're actually, oxygenating quite well. So all of that being said, this is sort of the summary of all of those pieces. So when you're doing your respiratory assessment, you're looking at their vital signs, their work of breathing, their behavior. Remember, infants will often present with poor feeding, and you're looking at their color, their circulation, their perfusion. I often get asked about, kids, if they have RSV versus COVID versus adenovirus, do I care what virus they have? Sure. But in the moment, airway management is about supporting and treating what you see and hear. Whether they have RSV or COVID or all of the above, it's really just about the management of what we are seeing at that moment. So next is circulation. I'm talking as fast as I can. I'm like, so circulation. So you've done airway, breathing, circulation. You're assessing your central and peripheral pulses, your skin temperature, their color, their perfusion, their cap refill, and you're going. So when I do a little infant, I start literally at the chest and I work my way down to check their perfusion out to make sure that I'm not missing anything. And I'm comparing central to peripheral to make sure that it's okay. At this point for nursing, sometimes we'll put them on a monitor at this time. Sometimes we'll think about, okay, this kitty probably needs an IV. They might need some fluids. So typically with kids, we'll give 20 mils per kilo of saline as a fluid bolus. With our neonates, our little ones, we'll usually just give 10 per kilo of saline. And we always reassess after every fluid bolus. A couple of special considerations with neonates. If a cardiac defect was suspected at this point, we might consider doing something called a pre and post ductal SAT or a 4-limb BP check. Sometimes you'll hear that your doctors ask you to do those and you might think, what what am I doing? So all a pre and post ductal SAT is we're checking a pre-ductal SAT, which is the baby's right hand or wrist, and that's before the blood goes into the aorta, and a post-ductal, which is either foot, so after the blood comes out. And we're just looking to see if they're the same or very similar. This is done at about 24 to 36 hours of life before baby goes home from hospital. And sometimes they pass this, and a few days later, they end up back, 6 days, 7 days of life. They end up in the emergency department. So that ductus, I'll go actually to this slide. That ductus arteriosus has closed, that patent ductus arteriosus has closed, and the blood can't shunt anymore. And that's when the baby starts to get into some trouble. So we do a pre and post ductal SAT. So you want your SAT fairly similar. If there's more than a 3% difference, then we're very concerned. And then your doc will say, do a 4-limb BP. So normally blood pressure is higher on the legs than the arms, but not the case with something called a coarctation of the aorta. So what that we will see in our babies is they'll have sort of like their upper limbs will be flushed. They'll have bounding pulses up here, like very flash cap refill, and their blood pressure is higher on their arms. And when I start to go down to their legs, the perfusion in their legs is really, really poor. They have weak or absent femoral and pedal pulses. They're mottled, they're cool, prolonged cap refill, and their blood pressure is actually lower in their legs. Pre-ductal SAT will be much, much higher than their post-ductal SAT. And right away, I'm thinking, I think this is a cardiac baby. And it is a medical emergency. And this coarctation of the aorta is the most missed congenital heart disease. These are often the kitties, our little babes that might present day 3 to 7 of life in our emergency departments. And they often come in grunty, tachypneic, or feeding. They might be a little bit cyanotic when they're crying or feeding. So these are the babies that we want to pick up on pretty quickly. And then we treat them with prostaglandin. Just a couple points about cardiac when you're checking sinus tachycardia. So all our kids usually come in tachycardic, and you're thinking, why is every kid tachycardic? It is an early indicator of shock, but there's lots of causes of tachycardia: fever, dehydration, pain, etc. And what it is heart rate drives cardiac output in children. For adults, our stroke volume, which is the volume of blood pumped by our ventricles each beat, is what controls our cardiac output. So our stroke volume increases, our cardiac output increases. But infants and toddlers have a very limited ability to do this. So instead of pumping more volume of blood, their heart just pumps faster, and that's what increases their cardiac output. The problem is if their heart is beating too quickly, that diastolic period drops and the ventricles can't fill, and then their stroke volume drops and their cardiac output ends up dropping. So heart rate is an early marker. A lot of kids will come in tachycardic, and they might just have a fever. And so once you treat the fever, the heart rate comes back down. But you have to figure out why they're tachycardic, right? So this is the reason they become tachycardic, but it's important to treat the cause of it. The opposite would be bradycardia. And I can tell you right now, I would take a tachycardic kid over a bradycardic kid every day of the week. Bradycardia is most commonly caused by hypoxia, acidosis, severe hypotension. And if a child has been really tachycardic, and then all of a sudden they're bradycardic, and then they might come up and they're tacky, or, they're tacky, but maybe not as high as they were, and then they brady on me, it's a red flag. Sick babies especially don't like to be handled. And if I'm poking them for IVs and I'm doing stuff, sometimes they'll have a brady and an apnea. Sometimes we call them A's and B's, and they kind of go together. It's an ominous sign. It's not a sign I want to see, and I want to make sure that I don't delay therapy. I want to get on them quickly, and I want to check their perfusion, and I want to go through all their systems to make sure I'm not missing something. And remember, with peds, any heart rate less than 60 and the poor perfusion is high quality CPR. The last little part of of the cardiac assessment, not to forget and not to overlook, is blood pressure. Blood pressure is very important in children. It's a late clinical marker. Kids have a really strong compensatory mechanism of protecting themselves, but they have limited reserves. So it depletes quickly. Kids can keep their blood pressure until they lose up to 30% of their intravascular volume, which is a lot. So when they can no longer increase their heart rate and vasoconstrict to keep that cardiac output, they'll start to decline. So I always explain, if you've ever heard me talk before, I always explain it the same way. It's like being at a ski chalet. I want to get a kitty when their blood pressure is normal and they're at the ski chalet drinking hot chocolate by the fire. I don't want to start treating the patient and picking up on them being sick when they're at the top of a double black diamond hill, starting to slide down the hill. It's much harder to pull them up a double black diamond hill when their pressure is already tanking than it is to get them while they're still at the chalet, nice and warm, and I can treat them there. So if I sort of think of it that way, blood pressure is late, but I need to pick up on all the other signs that we just talked about before that blood pressure starts to change. Okay, and it's important to know what your pressure limit should be. So for your systolic pressure, neonates should be greater than 60. And a quick way to kind of know it, if you know their gestational age is 40 weeks, their mean arterial pressure, or their MAP, should be at least 40. That's sort of a quick and dirty way to kind of do it. Infants should be greater than 70. Our kiddies 1 to 10 should be 70 plus 2 times their age. And our kids should have a systolic of greater than 90. Anything less than that, they're hypotensive and we need to treat. So we've done airway, breathing, circulation. The next two kind of go together. Disability, so I'm checking their GCS if I need to, their temperature, and their glucose. Those are two very valuable. So if you kind of go through your systems, you're not missing something. Check your temperature, check your glucose if you need to, especially on a neonate that's not been feeding. You need to know what their blood sugar is. and you need to treat it pretty quickly because that can alter a lot of different systems. And then, don't forget, if you've got your baby, you've kind of gone like this down, make sure that you actually roll them over, look at their back, take their diaper off, and make sure that you're not missing, a rash or an injury or something on their back, but keep them warm at the same time. Kids and babies don't like to be cold at all, especially our neonates, our small little infants. They have a very limited ability to keep themselves warm and regulate their temperature, and they become something called cold stressed, and they become apneic, bradycardic, hypoxic, and hypoglycemic, and they get themselves in this vicious cycle, and sometimes it's hard to get them out of it. So we always want to make sure when we're assessing our small kids, especially in our babies, that we're sort of methodical in how we do it, and we don't just strip them naked and start, poking away at them. If you have a warmer in your emergency department, I would always suggest to nurse a neonate, especially on a heated warmer. That way you can have them exposed, and you can do IVs and whatnot, and you're not worried so much about their cold stress. Minimize drafts. If you can't do that, you could always put a warm blanket underneath them and a warm blanket on top of them. There's other things we can do, warming fluids and things like that. But don't forget that cold babies don't like to be cold. So if you have a baby that's all of a sudden having apneas and brady's and otherwise was okay, check their temperature and see what their temperature is. If they're really cold, that might be what's happening. So think of it this way. Kids are like a three-legged table. I like my analogies, as you probably have figured out. Kids are like a three-legged table. If one of the legs collapses, the table collapses. So they want to be warm, pink, and sweet. That kids want to be normal. Everything normal if you can. So warm, pink, and sweet, or else the table collapses. And then the last couple of things that we talk about are, if you do your alphabet, airway, they've got it. Breathing, yep, it's a problem. They're breathing too fast. Circulation, yep, their perfusion's not so great. Glucose was okay, and my disability, they're febrile. I'm going to make sure that I give them some Tylenol. Exposure, I flipped them over. I looked at everything. I don't see any rashes. I made sure that they're warm. F. Oh, I forgot to do a weight. Okay, I'll do a weight. I'll make sure I do my vital signs now. I'll make sure to push that blood pressure cuff to have it go off. Weight in kilos for kids. If you're not sure, take a Broslow tape, start it at the head, and pull their legs straight and do it right to their heel, right? So that their foot is straight. You don't point their foot forward, you do it to their heel. And wherever that lands is what weight they're estimated at. And a Broslow tape gives you all kinds of different information. Sizes for tubes, fluids, chest tubes, endotracheal tubes, etc. And don't forget about families. It's one of the most difficult parts of pediatrics are parents and families, but it's very valuable to have them there, especially if you have a child that is having a cardiac arrest or is not doing so well. Families need to be in the room if they want to be. Which sometimes is more difficult for us, but it's important part of family-centered care. If at all possible, if you have somebody that can be with the family to help talk them through, that would be beneficial, obviously. Some of our smaller sites don't have that luxury, so sometimes you have to do with what you have. But even if it's a unit clerk or somebody that can just be with the family, that is very helpful. And then the last couple of little points just to not forget is to make sure you get your adjuncts, make sure you do pain management, make sure you get a good history from the family. And when you think you're done, start again and reassess. Pediatrics is about reassessment. You do an intervention, you reassess. You give fluids, you reassess. I gave a medication. Most kids are medication naive, especially to narcotics and antibiotics. Give it, I check them. I need to make sure that they tolerated it. I need to make sure they're not allergic to it. I need to make sure that it's working. So it's all about kind of going back and just constantly sort of doing A, B, C, D, E, F, G. A, B, C, D, E, F, G. So that is what the nursing process is. So what I would do when I get a patient, actually, I'll show you quickly what I do. So I have my little pediatric patient that comes in. First thing I do is I take them out of their stroller or whatever they're in, and I strip them, right? Like I get them in front of me. I'm actually going to do it like this so you can see. I would cover them, and I'm going to start at the head. I put my hand on the head. I feel my fontanelle, and then I start at airway, right? So I'm looking at their airway. I'm like, yep, looks good to me. They look like I don't see anything in the mouth. If I needed to do some interventions here, I would. Then I would pull the blanket back. I would start at the chest. I would take my stethoscope and I would do my listening for my breathing. So I'm on B. I'd have a listen to the heart. And because I have a stethoscope, I would listen to the belly because I'm here and I'm not going to, it just makes sense to do it. And I'm looking. As I'm doing my stethoscope, I'm also looking visually. And then I put my hand on them and I start feeling their cap refill, their skin temperature, and their color. And I'm like, okay, I know what that looks like. And then I go down both arms. I feel peripheral pulses and central pulses. So for an infant, I would feel brachial pulses on both sides. If it's a pediatric patient, I would feel radial pulses on both sides. I'm feeling their skin temperature. I'm in their hands. I'm feeling their cap refill, looking at their color, their temperature of their skin. And I'm looking, I'm comparing the both sides. I'm like, okay, I've done that part. I would cover them. And then I would come down to their legs. If they're sick, I would definitely pull off this diaper and have a look to make sure everything looks okay. I would feel femoral pulses both sides. And then I would slide down their legs, feeling temperature, color, and I would go right to their feet for pedal pulses, and then I would do cap refill. So I've done A, B, and C. Disability, I would check now. I would come up. I would check their temperature under their arm. And then I would say, okay, I would throw on, if we all know this all gets done simultaneously. Somebody's probably put a blood pressure cuff on. Someone's put a sat probe on. I would make sure that those are done. If I need to do a glucose, I would do my glucose in there. And then I would say E, exposure. I'd make sure I flip them over. And then I'd say F, I've done all my vitals. Yep, I'm good that way. I'd talk to the family. And then I would make sure that I got labs. I would start my IV. I would push my fluids, etc. So you kind of go through your systems. And as soon as I do an intervention, remember, I'm reassessing again. So it's like a constant process that you're going through here. And we know most of the time there's more than one nurse in the room. So as long as somebody is in charge of going through A, B, C, D, E, F, G, because you can't start an IV and do this and do all that immediately. Somebody has to go get the stuff and, so it does not take long to do a really good, thorough assessment. So now we're going to watch a couple of quick videos, and then at the end, I can open it up for some questions. So what I really want you to do when you're looking at the videos is think about the pediatric assessment triangle and think about what's altered and what's off on these kids. So hopefully these all play for us.
There we go.
So you could hear that, right? Yes? Okay, good. So when I look at that video, I immediately think, okay, the baby is alert. She's looking around. She hears the monitor. I'll play it again.
There we go.
That is the perfect example of grunting. That's exactly, my guess is this baby probably has bronchiolitis, and this baby is grunting to open all those little lung spaces in her bottom of her lungs to keep the alveoli from collapsing. So she's definitely grunty. So her work of breathing's off. We know that she's got a strike there. Her cheeks are quite flushed, but she's alert. She's looking around. I don't see any cyanosis. It's hard to tell whether or not she's mottled. She might be a little bit centrally, but she's also stripped naked in an emergency department. So she's probably a little bit cool. So I would deem her definitely sicker, and I would want to get her back, and I'd want to start giving her some treatments and get her assessed quickly, because she can only grunt for so long before those weaker intercostal muscles, her weaker, she's going to get tired. That's sort of the number one reason that kids end up going into respiratory failure. They get tired. They can only grunt and, breathe like that for so long before those muscles start to become a problem. So this little squirt, so when I look at him, he's alert, he's looking around, he's very tachypnic, he's quite tachypnic. He has an audible wheeze that I can hear. He's pale pink. I don't really see any cyanosis or pallor. It's hard to tell in some of the videos. So again, I would deem him sicker, and I'd want to get him in, but is he the sickest child I've ever seen? No, but he's definitely a baby that I'm concerned about, and I definitely wouldn't want to just leave him for hours because he's not going to be able to breathe that quickly for a long time. Now, right away, when you look at this video, I think you're going to see immediately, before I even play the video, this baby does not look good. Like, instantly.
Đừng làm mà cái gì để ăn nữa. Không có gì. Này, có phải hai người trước đây có tình ý với nhau không hả? Ai nói vậy? Đừng làm mà cái gì để ăn nữa. Không có gì. Này, có phải hai người trước đây có tình ý với nhau không hả? Ai nói vậy? Người anh ấy.
So when I look at this baby, he's doing a lot of things that I don't like. He's head bobbing. So that's what head bobbing is. So their head kind of bobs every breath they take. The baby looks kind of glazed over, kind of staring. Mouth is wide open. Nostrils are flaring. Definitely has a lot of retractions going on. Looks pale. Just doesn't look good. To me, every side is off on this baby. And this would be the baby that you take right into your resuscitation room and start working on. Again, you can still do your A, B, C, D, E, F, G, because somebody is starting to go through the systems as you're getting things organized. As somebody's getting the IV supplies and somebody's putting the child on the monitor, still you're checking airway, breathing, circulation, because right away you can see this baby's not going to have normal circulation. This baby just looks terrible. I mean, there's no other way around it. The baby doesn't look very good. Okay, so this one, we'll play this guy.
Hey, put your hands down for just a minute, big guy. I want to demonstrate your breathing pattern. So he very well may be one of these new enterovirus 68 infections. He's never wheezed before, and has had a couple of days. Mom, Dad, you were telling me it's been how many days? 3 days, and that when did he really get short of breath and start working?
This morning.
Yeah, so you can actually see the intercostal retractions. You can see the abdominal breathing. He's working a little bit on his chest here, a little sucking in, super clavicular, super sternal anyway. My videos go on YouTube, but they're basically teaching videos, so people learning what to look for will recognize it. What's his pulse oximetry?
Originally it was 91 on room air.
Okay.
Right now it's 95 after the first treatment.
He's had one breathing treatment, so he was actually even worse before the very first time.
So
So
we already do the second one.
okay, thank you.
Sort of example, we can get that up there, of a child that's alert. You could see that he was playing with his lead. He's definitely, looking around, things like that. He definitely has a lot of retractions. He's pale pink, but he's not a kid, again, that I would want to just leave for hours before reassessing. So I would deem him as sicker. Play this one.
Do you know what's going on with this patient? You can see his breathing. See how fast it is? See what's going on with the ribs? Do you know what it is? My name is Dr. Carlo Ojed, board certified emergency physician with
Fast words. We talked a lot, that fella. So you can really see his ribs sucking in there.
Say, no, we can treat this here, and then if he doesn't improve, then we'll transfer him out.
Hello there, Dr. Carlo Ojed. In this video, we're gonna see a very clear example of respiratory stress. This patient had clear intercostal retractions, which is when each patient takes each breath, you can see the ribs coming out underneath the soft tissue. And this is just a superb example of intercostal
Oh, he paused.
retraction. But he also had suprasternal retractions as well, which we'll see in the video.
This is what we call suprasternal retractions. You see
That's
the
a really good example of
soft
a
tissue becomes
tracheal
more
tug right
prominent
there.
every time he breathes because it's pulling. These are what I call intercostal retractions. Every time he breathes, we can see the ribs, and those are obvious signs of distress. And of course, the speed of the breathing, which is what
Yeah, I even tried telling him to put his hand over his head and take deep
probably
breaths.
40 something a minute. You think, Justin?
It's like 46.
46.
So he's breathing at about 46 a minute, and he's probably 10 or 11. So he's pretty quick.
Now, let's take a listen to what this patient sounded like when listened under a stethoscope. I used the echo stethoscope to listen to this patient's lungs, and here's the sounds. That sounded pretty terrible, right? And that's after giving the patient Decadron. We gave him 8 milligrams IV. We gave him a Duoneb, which is albuterol, and ipratropium nebulized treatment. And he was still breathing 40-something times per minute. He was still having audible wheezing. You can see the retractions, intercostals, suprasternal. And the kid was getting tired. So we wanted to get the patient admitted for further treatment. However, our hospital does not have a pediatric floor or pediatric specialty, so we decided to transfer the patient to Children's Hospital for further treatment and evaluation to keep him managed there. Other things we did is we increased the Decadron's IV dose. We gave a repeat nebulized treatment. This time we used Sopanex, and we also started a magnesium drip. Magnesium is used as a second-line agent for the treatment of acute bronchospasm or asthma. Because what it does on the smooth muscle is relaxes it. So it allows those tight airways that have muscle fibers in it, they're all contracted and tight in an airway disease, to get dilated so the patient has more air going through and the work of breathing be better. So this is a very superb example of severe bronchospasm or asthma attack in a pediatric patient. Probably one of the worst I've seen in a long, long time. And it was really amazing to be able to record those sounds and share them with you, that the family members allow us to record the retractions so that you can see it, hear it, and learn it. So I hope you learned a lot with this.
Okay, perfect.
Do you
So obviously this patient, he explained pretty much everything I would have explained. That's why I let the video play, because he's actually quite good. So the patient's very lethargic, tachypnic, obviously has a prolonged expiratory phase, a lot of retractions, the tracheal tug, and is wheezing quite significantly. So you heard the physician explain sort of the treatment pattern, and this is a perfect example of an asthmatic attack on a pediatric patient. So if you've not, you've probably heard Kussmaul respirations. What are Kussmaul respirations? This is a really good example of what Kussmaul in a pediatric patient looks like.
Okay, so mom's letting me capture some video
Yeah,
here.
I've got a syringe.
This gentleman
somewhere in
just
my
came in
desk
from
here.
a pediatrician's office. He's 10 years old, and you hear his breathing. This is Kussmaul breathing. This is the breathing that you see with diabetic ketoacidosis. He's a little bit altered. He's a little bit slow to wake up, so he's pretty severe. He's had some weight loss, and then he's been having some vomiting.
Notice he's not bothered at all by the IV pump in his arm.
No, this is new. This is brand new.
Gotcha.
He's had no prior documentation or diagnosis of DKA or diabetes.
I don't.
Like I said, that's a good example. Let me just pause the video there. Move ourselves forward. So lethargic, tachypnic. And again, it's not because of a respiratory reason that he's tachypnic and Kussmaaling. It's because of he's trying to normalize his pH. It's part of that non or silent tachypnea that kids get when they're trying to normalize their pH for a non-pulmonary reason. This video always makes people a little weary because she's so sick, but kids look sick. And I want you to pay attention to how calm her caregivers are.
Good girl. Use your nose. Yep, good girl. You okay, sweetheart? It's
Gentle
okay.
breathing, gentle breathing.
I know, darling. It's not fun. But we're here with you, okay? Good girl. All the way out, darling. Good girl. You're alright. I'm gonna get high on with it too.
Slow, deep breaths, darling.
Slow, deep breaths,
Can you
babe.
go really slowly? There's plenty.
So you can see how scared she looks by her eyes. No doubt about it, she's one of the sicker patients that we would see. She's alert, but she is terrified. So it's really important as nurses that if we can come down to the patient level, sit beside them, hold their hand, try and stay as calm as we can, that really does reflect back onto the patient and does help. You notice that she's in a position of comfort. She's sort of tripoding herself forward, and that's important to let patients sit how they feel most comfortable to protect their own airway, if at all possible. The next video, the last video I have, actually shows you an example of how a patient looks uncomfortable to us, but it's obviously how he's protecting his own airway. Before I even play the video, he doesn't look great how he's sitting, but that is how he is protecting his airway. Notice that paradoxical or seesaw breathing pattern. I'll play it again because it's not a very long video. And you see how he's really forcing that air. He's really pushing to get the air out. His jugular is distended. He's a very sick little guy. Letting him sit with his mom is probably the best idea right now because he's probably the most comforted by her. And if we can do any treatment while he's with his mom, all the better. So sometimes it's uncomfortable for us as nurses. We want them in their bed. We want them, in the position we put them in. But sometimes it is about sort of playing the game and doing what is best for the patient. In this case, having the parent hold the child and doing our care around that is what is needed. So the very last slide that I have is just a few resources that we have in the region. So there's lots of different things out there that nursing and physicians can use. Trek is a big one. It's a Canadian resource. It has all kinds of algorithms for all different things: bronchiolitis, DKA, sepsis, trauma. We have our asthma, our clinical handbook for asthma that goes over the PRAM score and what medications we should be giving for pediatric asthma. We have tons and tons of videos available about kids' health. Trek has lots of videos for families. PCMCH has lots of resources, the Canadian Paediatric Society. So there are a lot of different resources out there. There's lots of different courses that are available. I would always suggest that nurses in emergency departments should take the Emergency Nursing Pediatric course, ENPC. It's a really great course. Pairs and PALS are other really good, valuable courses as well. We have from MNCYN, we have a whole series of respiratory videos that are available on our YouTube channel that go over high flow and they go over MDI treatment, nebulizers, all kinds of things like that, how to do a respiratory assessment. So what I'll do is I'll stop sharing. I know that was a ton of information that I just threw at you. It's hard to get it all in an hour. So I'm happy to open up the conversation if anyone has any questions for me. Oh, I'm sorry. Somebody said they couldn't see or hear videos. I'm sorry about that. I couldn't see the chat while I was talking. Apologies. Are there any questions or is and anyone have anything they wanted to ask or talk about? No?
Hi, it's Jane. Thanks so much, Kristine. This was really a wonderful review. Can you just show me that little handy suction device that you had? We have a small emergent and a rural emergent. If you could just show me the picture of it, it seemed like it was a great little suction catheter.
So they're called
Okay.
little suckers.
Yep.
Can you see that?
Yes.
And
Okay.
they actually have an HDMI, or they have a little code. I think HMS, no, what is it? HHMS from the hospitals. I'm pretty sure that's where they get them. So this is what they look like. They have a Prem one as well, which is a little bit smaller. This is just the one for infants. But to be honest, I've used these before on bigger kids as well, because they fit perfectly up the nostril. and they're a little, like I said, they're a little bit more rigid, but they're not like, it's not as hard as a yonker. And they fit really nice. And if you just do a couple of drops of saline first, and then you can get them up each nostril, you can get a lot of secretions out. And if you can get them breathing better, obviously then they might be able to eat as well.
Great.
When do you make the switch from treatment and mask to giving pressure? How long, what might that take? I assume, Donna, that you're talking about going to high flow. And that's a great question. So we actually, I on the Ontario Health West Clinical Quality Working Group, and we have a brand new algorithm for high flow, when to start it, etc. That is coming out soon, like imminently. And we're actually doing some webinars starting next week on how to go through the algorithm and how to know when to go from low flow up to high flow and giving some pressures. So Donna, I'm happy to share the webinar link with you if you'd like. If you just pop your email in the chat for me, I can send that to you. The 4-limb BP check, honestly, it's more for our neonates, right? That we're concerned about some sort of cardiac defect. So usually we'll only do it sort of in that first, 2 or 3 weeks. We wouldn't really do it past the 28 days that we're looking for those cardiac defects. Every now and then there's that kitty that slides through the cracks and they come in and you're like, this can't be a cardiac. They're too old, and they are cardiac. So it's more for our neonatal population. Carrie just said in the chat as well, the QR code poster. I did send it out to Ontario Health West region to my contacts. I think it was yesterday. And I'm happy to share that out again. That is a good resource as well that we just put together. So thanks, Donna. I got that there. Are there any other questions or comments? I realize, like I said, that was a lot of information that I just threw at you in a very short period of time, but I am hopeful that you feel more comfortable and confident now that you've got a little bit more pediatric knowledge under your belt, so that when a kitty does come in, that you know sort of some of those signs and symptoms of distress. Great. I see all the emails coming in the chat, and I'll make sure that I include you in those. All right. Well, that's the end. Thank you so much, everyone. Have a great day.